Hi, everybody. It's a pleasure to welcome you once again to our symposium. Today, we will have two cases. One will be presented by Fabio Tendoy, the other one by Zé. Hello, Fabio. Hi, Zé. Thank you for accepting to present. And as usually, you can ask your question and post them on the chat, and please answer the polls. We have two polls today about the cases. So to start, I would like to share with you just the case we discussed last time with the IWC Istanbul team. It was, I will share my screen just right now. If for the people who were connected last time, it was a case of chronic instability of the CMC1 joint. It was presented by Bülent. I don't know if Bülent is connected now. And if you remember, we discussed some therapeutic options, the CMC fusion, the ligamentoplasty, trapeziectomy with suspensionsplasty or tendon interposition. And finally, Bülent proposed the arthroscopic CMC debridement in this young patient, as we can see here, and stabilization with the CMC ligamentoplasty using the tightrope here, because the patient was a young patient. There was a safe cartilage in the CMC joint. So at this moment, Fabio proposed his technique, and today he will present the technique he works on with, I think, Lucian, Riccardo Lucchetti, Andrea Zé. Fabio?
Yes.
So thank you, Fabio. If you can share your screen, present your technique.
You.
We can hear you. Hello, Ezekiel.
Okay. Can you see my screen?
Yes, we can see your screen, and we can hear you as well.
Okay, perfect. Thank you for the invitation, Helen, for the opportunity to speak about acute dorsal carpal metacarpal ligament repair by arthroscopy after dislocation. Carpal metacarpal dislocation represents less than 1% of all hand injuries and happen after axial trauma, resulting in damage of the complex dorsal ligament, which can injure the trapezium or more often the metacarpal insertion. We recommend asking for a CT scan for each patient because the fracture of the trapezium of his metacarpal should be reallowed. This is a case. In this case, first, after the diagnosis is confirmed and reduction is performed, the tomb is unstable and the dorsal complex ligament should be repaired. This is my case. After reduction, we can see the joint unstable. This is an acute case. This is a moment to ask the people here, what's your opinion about this case? What do you do in this type of cases?
Thank you, Fabio. So we are in an acute case of CMC instability post-trauma. We are at, what is the delay since the trauma, please, Fabio? About
the
delay. No, the delay. When was the trauma?
2 weeks ago.
Okay, perfect. So I think we can ask our panelists what was your preferred therapeutic option in this acute case. I see already Vitale. It's very hello, Vitale. How are you?
Good morning. Good morning, everybody.
Happy to see you.
Good morning, everybody. Very interesting the case. So my first question is, as you said, not always this kind of dislocation appears to our clinic, our observation in the same day or the day after, 2 days after. In your opinion, what are the delay? I feel an acceptable delay to do to perform a repair as in the acute presentation.
When do you consider it is an acute, semi-acute, or chronic? I think that is a question
Yes,
from Vitaly.
exactly. What the maximum delay in your experience?
Remember, this case is not often. I have 3 cases in my history with a hand surgeon. In these 3 cases, I repair early, before 2 weeks, because after this time, the ligament weakens shorter and it's more difficult to repair it.
Okay. Thank you.
Thanks. Is there any other comments? For example, Von Leo, do you have any experience in this kind of cases?
No, I don't have experience in this kind of cases because the only one I saw in my life, it was a chronic case.
Yes.
So I have no experience in these subacute kind of cases.
Okay. Yes, it's a very rare. Of course. I have a question, Fabio. Do you ask systematically for a CT scan to check the cartilage?
No, the
What
CT
is
scan rule out the fracture of the trapezium or the first metacarpal. This is very important because the energy of the trauma is higher.
And what about the MRI to check both bones, cartilage, fractures, and ligaments? What do you think about this therapeutic option?
The problem in my country is if I ask MRI, probably the patient delayed more. And I prefer in this case to program or to schedule surgery because for me it's better perform arthroscopy and I can check the stage of the cartilage than MRI.
Okay, so the arthroscopy is, we know the arthroscopy is the most effective for the cartilage. Is there any other question? If not, I think, Fabio, you can go on with the case. Thank you.
One question or continue?
I think we can go on with the case because there are no other questions.
Okay.
Thank you. Except I can see Ezekiel is connected. Ezekiel, do you have any? Hello, thank you for connecting. Do you have any comment for these acute cases of CMC or any experience?
Oh, yes, Alam. My first question is, what should we do if after 2 weeks in the X-ray or the CT scan, the joint it is reduced? I mean, does anyone believes that surgery is always needed in this kind of injury? Because the literature about this is it is quite controversial because the outcomes of close treatment it is basically similar for acute injuries. So I don't know. It's like obviously at least in the cases that I treated, I treated all of them surgically. But does anyone believe that there is a place for conservative treatment for this kind of injuries? Maybe I don't know.
Yeah, I think the fear is not to treat them surgically and after to face a chronic case. And it is our fear to everyone. I agree. Fabio, what do you have to answer to Ezekiel?
No, in my opinion, it's very important to check the stability after reduce the joint. But if the joint is unstable, probably this case is in a chronic unstable of the CMC joint. In this case, it's very important. If I check with the test and the joint is continue unstable, this is the case. We need to repair or perform some treatment.
So Fabio, you think when the in the acute case the CMC is unstable, it's definitely not an indication for the orthopedic treatment. That is your opinion? Okay. What do you think about this, Ezekiel? Are you convinced?
Oh, well, I believe that that's a problem because the conservative treatment is basically to put the patient on a cast for 4 weeks. And if you check the stability on a patient 1 or 2 days after dislocation, it is obviously going to be unstable for the first days. That's what's going to happen in all cases. And if you use that criteria, we basically have to treat surgically all cases. So I'm not sure about this because I only treated 4 or 5 cases.
No.
And again, I treated all of them surgically. But that may be quite controversial. 2 or 3 weeks. If I have a patient if I receive a patient 2 or 3 weeks after an injury like this one, I mean, I may explain to the patient both alternatives, and the patient can choose the what choice he decided. And also, and because I also received patients with CMC dislocations that were really, really unstable, and the patients suffer a dislocation during with the cast put on. So those kind of injuries are really, really unstable, and we have to we have to do a really close follow-up of those patients. But that's my only comment. It's like I have more doubts than answers to this problem. So I'm sorry, Fabio. It's like
No. We totally agree. I think the question is, there is a chance when we have an unstable CMC, there is a chance to for the ligament to heal just with the immobilization. And I think the level of evidence we have from the literature is not enough, definitely. Yeah. But it is just my opinion. Thank you.
I agree.
Yeah, thank you, Becky, for this good comment. So, Fabio, I think you can go on with the case now. Yes, the arthroscopic treatment.
The discussion here is very important. One of them, my 3 cases, I remember my one colleague put in a case, and the one CNC joint continue with our reduction. And this is, for example, is a good case because the bone continue dislocated into the cast. Okay, but obviously we can continue with the discussion and the things.
I think you can go on with the presentation of the case.
This is on the traditional treatment option today are claw reduction and immobilization, claw reduction and fixation with Kinnear's wire, capsule and ligament reconstruction by open technique, ligament repair by open technique too.
So I will just stop you. I shared the polls for our attendees. So 14 14%, sorry, were for the close reduction and the immobilization. We have 64% for the close reduction and key wires fixation for surgical treatment, capsule and ligament reconstruction for 7%, and 14% ligament repair with open technique, and only 7% for capsule and ligament reconstruction. So we have 14% for the immobilization only, and the other people for the treatment. Thank you, Fabio. You can go on.
Okay. Our proposal is we understand the importance of the complex dorsal ligament in the carpal metacarpal joint, so we want to propose repair these ligaments too. Why do we do it by arthroscopy? Arthroscopy offers many benefits in these injuries. It's less invasive and painful, causes minimal scarring, avoids damage in other tissue around the joint, preserves ligaments and nerve terminals, and facilitates repair of the complex dorsal ligament, increasing the stability and preserving the joint. We use the technique described by Marcovici, Lucetti, and Atzei, and the most complex performed on the carpal metacarpal joint. We create one U portal first, then one air portal, and finally enter the trocar into the one U to create the tenar portal. Here it's important to know The 1U portal is between or in the middle of the APL and APL tendons. The anatomy of the portal should be known because the radial nerve passes through near the 1R portal. However, the 10R portal is safer than the others. Here the video, this is a question about Halan. My scope is in a 10R portal. This video shows the arthroscopy used in the 10R portal to visualize the injury to the complex dorsal-radial ligament and rule out the damage to the cartilage. Scope in a 10R portal, and we can see the complex dorsal-radial ligament. Now the hook is introduced into the 1R portal to check the complex dorsal-radial ligament and confirm if the level of the damage is from the trapezium or from the first metacarpal. This is very important because not always the damage is from the first metacarpal. We can see the scope in the 10R portal, we can see the complex dorsal ligament, and we can see hook in 1R portal, and injury of this complex ligament is from the first metacarpal. After confirming the severity of the injury, the suture anchor is positioned near to the joint on the first metacarpal, in this case, through the 1U portal, if that's the location of the injury. We can see the suture anchor throughout the 1U portal in the base of the first metacarpal. The next step is to repair the ligament. First, the needle is loaded with a suture lasso, so the loop in outside the needle, as it helps pull the suture into the joint and the ligament through 1U portal. When the needle is introduced, remember to be careful with the tendons because in the middle of the APL and APL tendons. We can see the suture lasso into the needle, and loop of the suture lasso is outside the needle. Now the needle is introduced through 1U portal, scope in 10R portal, and we can see the needle and suture lasso pass through the 1U portal and the ligament. Now the mosquito enter in the 1R portal to grab the suture lasso. When the suture lasso is securely held by the mosquito, the needle is removed. We can see the mosquito enter in 1R portal and now grab the suture lasso. And this is the moment to remove the mosquito and partially the suture lasso. Of the suture lasso, and we can rule out the suture lasso through 1R portal. But in this moment, it's important they have a loop of the suture here because the suture need to run around the ligament. The mosquito now at this time is loaded with the suture lasso to the loop enters in the interface, and the needle should be passed through the other section of the complex dorsal ligament. Remember, be careful with the tendons, and the all other steps are the same. We can see the suture lasso in the needle, but now the loop interferes or is in the top of the needle. Enter again and the 1U portal, but in the next part of the ligament, we can see the loop of the suture lasso interferes, and now mosquito enter through 1U portal to grab the suture through the loop of the suture lasso. The mosquito with suture lasso is removed from 1R portal, and the suture lasso is pulled out from the 1U portal. At this moment, the traction is, the finger is released. Here is important to check the suture doesn't pass through any tendon, nerves, or blue vessels. here to remove the mosquito, and we can rule out the suture lacer, and we can see the suture run around the ligament, and we can check the tension of this ligament. Finally, the CMC joint is reduced and the suture lacer is tight. In this case, we can remove the stitches after 7 days. The stability of the thumb is checked, but the splint should be used for another 3 weeks for irrestricted until week 5. This is 7 days after when I remove the stitches, we can check the stability. And this video is 1 month after the surgery. We can check the stability again, and we can see the move of the finger, thumb finger. In conclusion, arthroscopy is a good option to repair the dorsal complex ligament of the CMC1J. It is a limited risk and causes less injury, allows magnify the bone and soft tissue, allows a more anatomical ligament repair, and avoid complex joint reconstruction. Thank you.
Thank you so much, Fabio. It's very nice presentation. In my opinion, what is very interesting is the minimal invasive technique, because if you have to repair it open, I think the outcome the outcome would be less good. But it looks technically demanding. How was your learning curve, Fabio, for this technique? Because you have 3 cases.
3 cases.
It was easy, difficult. Can you just tell us a little bit more about the learning curve? Because when you look at the technique like this, we have 5 steps. Is a little difficult.
It's not difficult. We have a take care with the step by step, because if done has a loop when the pass in the second pass, when I show the case here, it's very important to have at the end of this phase, I have in one case have a problem, because I run all suture and don't have a loop. It's difficult to run the suture around the ligament, and in this case I need to repeat step by step. But the other steps is not difficult. It's easy technique.
Thank you. Can you stop sharing your screen, please, so we can do a very quick roundtable? Thank you. Do we have any comment in the panelists? Or I have Clément and Mort after. Clément.
Yes.
Hello.
Thank you, Alain. Thank you, Fabio, for this great case and great technique. I have 2 questions for you. The first one is, do you, in your 3 cases, do you put a key wire to protect the reparation after the surgery? And my second one is during your arthroscopy, you check the anterior oblique ligament, because it's also a ligament which is important for CMC stability, and you check it during the surgery. And if the ligament is damaged, do you propose something like a shrink or something to complete the reparation?
I don't use any K wires for give more support in the joint. And no, for me, the most important, the all investigation or papers show the most important ligament is in the carpal metacarpal joint is a dorsal complex ligament, and this is checked with a hook. but the other ligament in these three cases, I don't check.
Okay.
Why did I check?
Do you think there is we can have a concomitant a pattern is concomitant ligament, the palmar and the dorsal ligament that can be injured, or it doesn't exist, the concomitant lesion? Because I think it's not so frequent to have concomitant lesions. Fabio.
We can exist, but at that moment, I didn't check this ligament.
Okay, thank you. I have Mort and after Ezekiel. Mort, do you have a question or comment, please? Yeah.
Thank you, Fabio, for your great presentation. My first question is, do you routinely check Batten score for all the patients? Because sometimes the patient may have a hypermobility syndrome. And then, as we know that CMC1, the two volar oblique ligament is also important. So, do you think it is enough repair dorsal capsule only in all cases, especially in the case of gross instability of the CMC1?
I think you have the same question now.
I have experience about 3 cases. I just do open, so it still can give a good outcome. I repair both volar ulnar ligament and dorsal radial ligament.
So Mort, in your 3
you.
cases, the volar were injured as well. You have
Yeah,
concomitant.
that's right.
Okay.
Yeah, I have concomitant both dorsal radial and volar ulnar ligament.
And you did the repair just in acute cases.
Yeah,
Okay.
I repair both too. And then my third question is up to if there is no remnants of the ligament, can you do this technique? If no remnants of a ligament, especially in the chronic cases.
It is here in the acute, but you can answer, Fabio, please. Thank you.
In the chronic cases, probably need to more stabilization, because I don't know if when I enter my scope, probably the ligament is shorter and it's impossible to repair. In this case, it's a good option to capsuloplasty with this technique, dorsal capsuloplasty, and overly plus mini tie rope help to get more stabilization of the joint in chronic cases, I believe. Because in my opinion, reconstruction is more difficult and more complicated than this type of techniques. And the other 2 questions, for me, volar, I don't know. I don't know. It's difficult. I don't know what is the best option for these cases.
We need a more series. Thank you, Morten. Fabio. Now we have Ezekiel. I have a comment question. Yes.
First, Fabio, that was a great presentation, but also I agree with all the previous Clement and Maud question, because I believe that it is impossible to have a CMC dislocation like the one that you show without an injury of the volar components. It's like if you check the volar components are gonna be injured in this kind of injury. And we may argue if repairing the dorsal-radial ligaments of the dorsal-radial complex is enough or not. But and that's usually my choice, just repair the dorsal-radial components. But I have one case in which it is a young rugby player, in which I just repaired the dorsal-radial ligaments, and the patient had persistent pain during weightlifting. And and in that case, I regret myself not repairing the volar ligaments. And I actually, and that's my treatment for acute lesions. But when I have chronic injuries, I go directly to repair the volar one. So I'm not sure what should we do with this kind of injury. I know that in most cases it's gonna work, but I'm not sure that just repairing dorsal is gonna be enough.
Thank you. Yes, yeah, we all agree that it's a very rare pattern, so we don't have enough large series about what is the best technique. Ezekiel, when you repair in the acute cases, which technique do you use? Which is your preferred option?
Well, in the cases that I treated, I just do it open and repair the dorsal radial ligaments and K-wires, and that's it. But after this presentation, probably I'm gonna try arthroscopic arthroscopy in my next case, but I have never done it.
Arthroscopic is always more seducing. Yeah. When
Oh yes, I definitely yes.
Who has an experience? Thank you, Ezekiel. Who has experience maybe? Or a question? I think nobody has question. We have a question from the chat after Vitale. Fabio Sujit is asking what's the diameter, the size of the suture anchor in your case, please.
1.0.
Okay, it's absorbable, not absorbable. It doesn't make any difference.
This is any different, no problem.
Okay, perfect. Thank you. And after we have Vitale, short question, and Marthe.
No, it's just it's just about the relative importance of dorsal and volar ligament of the capsule. I found an article about open repair of this kind of dislocation, where they say that the importance of volar beak is something more historical, and there's some works from Stroke. They said they mention in the article that put more emphasis on dorsal cadaveric studies and put more emphasis on dorsal capsular ligament. So I don't know what is if your experience. I did just once, and I did just a close reduction and pinning, but it was 3 or 4 years ago, and it worked. So I don't know if it was
so
just
for the volar dorsal, we need to organize.
I was just lucky, maybe, but I did it in an acute setting. But maybe I was just lucky.
Thank you, Vitale. Maybe we need to organize a regional club around the volar and dorsal in the future. Marthe, the last question, please, and after we need to go on, and after Leo, and we need to go on with the next case. Marthe, you have a question? No question.
No, I don't have a question.
Okay, so because the last question with Leo.
Okay, Fabio, do you release your traction before you tight your sutures?
Yes, when I have before tie the suture, I release the traction. When the suture is in a U portal, recover again, then reduce the carpal metacarpal joint. At that moment, tie the suture.
I have just a very last question, Fabio, please. Do you think because for some techniques such like the capsulodesis in the wrist or scapulonate, even in the chronic cases, we debride the lesions, we try to refresh them. Do you think in your technique here we can do the same for the chronic cases, or it's quite impossible to refresh because the ligaments are retracted? What do you have any opinion on this, please? Can we apply your technique to the chronic cases?
But we need to check if for me it's very important, if the ligament is shorter, it's impossible to debride only or repair. In this case, we need to additional technique. I suggest mini tie rope to combine with my capsuloplasty. In this moment, I don't repair the ligament. I will perform a capsuloplasty plus mini tie rope technique by arthroscopy, obviously.
So bull and tendon technique. Thank you, Fabio. Thank you, everyone. I think we need to move to the next case. Very controversial technique. Today we present 2 cases, and please be nice with Earth. Zay, you can.
All right.
We can see you.
Okay. Just give me a while. Okay, can you guys see this?
Yeah.
Okay, first and foremost, I'd like to thank Alam for this opportunity and presenting this case on her behalf. So we are from the IWC Paris. So presenting the first case, this is a 39-year-old male, right-handed carpenter. Injury to the trauma injury on the right wrist hyperextension 4 years ago. And 4 years ago, after he had the injury, had 2 surgeries elsewhere, but despite that 2 surgery, persistent wrist pain for 4 years, and came to see us as a second opinion. The pain was quite disabling. It was continuous with a pain score of 8. If you could look at the table on the bottom right, there is a reduction in range of motion. The grip strength is significantly reduced. And on examination and palpation, there was tenderness over the dorsal aspect of the wrist, the radial and ulnar aspect. So this was the initial images that was done 4 years ago when he had the injury, which showed a coronal fracture over the dorsal horn of the lunate. You could see quite clearly on the CT images over here. He had a headless compression screw fixation, dorsal approach, and you could appreciate that the screw is within the lunate and it looks relatively well reduced. X-ray looks relatively reasonably acceptable, and this was 4 years ago. 3.5 years later, after the screw fixation, screw was removed, and you could see these are the X-rays that was done 3.5 years after screw removal. So I think at this point,
Yeah.
We want someone to comment on that. And what are your thoughts about these X-rays?
So, Zay, you can choose someone because
Me? Of course, I need to get my best friend Tadeusz.
So, please, Tadeusz, you knew that when you connected.
No, actually, I didn't expect it to be chosen. Never mind. Thank you. Well, what I look at first, of course, we can look at lines. That's the first thing. The whole complex, I mean, lunates seem to be tilted ulnarly on the first AP view. So we see like half of lunate, it's on the tilted to the ulnar side. So this would be the first thing. And the other thing, what is the lunate seems to be very sclerotic and deformed. What may be connected with the pain the patient is expecting. Yeah. Yes. And diminished range of motion, diminished force, and so on. So, well, we see, I don't see any cyst and so on. I was thinking about that when you you have shown us the original CT scan, but well,
because it was a patient thank you, Tadeusz. It was a patient who was managed elsewhere in another hospital, and we don't have all the exams. We have the CT scan, but nothing else. Any other comment on the X-rays from the panelists for the management? Or okay, Zay, you can go on.
Yeah, actually, like what Teddy correctly have said, sclerosis of the lunate, it's noted on this X-ray. If you look really closely, there is arthritis over the mid-carpal joint where the capitate head looks a little bit fuzzy. And on a lateral view as well, you could see that there's a reduction in joint space over the lunocapitate joint. So this is the X-ray on the contralateral hand and wrist, just to basically compare. It looks pretty normal on the contralateral wrist. And so an MRI was then performed in this case. Do we want to ask someone, Alam, or should we? Okay.
For the preferred therapeutic option and comment the initial management, maybe.
Anyone have any thoughts about this MRI?
I can feel Lucian. He didn't say anything since the beginning. Hello, Lucian. He's in
Yeah,
the OR.
hi. Yeah, we can see that there is an edema of the capitate, and also there is some loss of bone inside the capitate, or a cystic formation inside the capitate. Is it true?
Yeah, yeah, it's true.
So
yep.
maybe the capitate has suffered a lot from the presence of the screw. I didn't understand if the screw was protruding dorsally or in the joint, or was put.
Can you come back, before to show Lucian, please, to the CT and the X-ray?
I cannot understand from the position of the screw if the screw had some relationship with the capitate, because here it seems that it had. And when you see the MRI, you can see the footprint of the screw on the capitate.
Yes,
so,
it was a question.
So I think that the main problem was an impingement of the screw on the capitate, and it quite ruined the midcarpal, the lunocapitate joint.
Yeah, I think like what you correctly said is true. Looking at the X-ray, the screw looks to be impinging against the mid-carpal joint, and obviously over the years it started to develop lunocapitate arthritis. Yeah. So these are the MRI images, like what you correctly said. There's a cystic changes over the capitate head. Lunocapitate joint is actually reduced. The arthritis is quite severe, and the joint space is actually, the bones are pretty much touching each other. So what is our next management? What should we do? I'm not sure if anyone has any comments on that.
I can see Ezekiel, Paula, someone would like to, what would be your management here in this young, not really young patient, hand worker?
I would do an arthroscopy to study better the joint, to evaluate what I have good and what I have that is ruined. And I will also evaluate the ligaments, because you told us that it was an open approach, dorsal, right? The first operation.
Yes. The point is, in this case, this patient, he was a hand worker. He had a very, very bad experience with the first surgery, and with the first surgery in the first hospital. He refuses. Now the concern is the pain, and it is the main concern, the pain, and also the strength. And he refuses. Sometimes you need to deal with the patient. He refuses any kind of hardware and no implants.
So you're asking what would be my treatment,
yes,
or what?
Your treatment, yeah.
I think that in this kind of patient, I would do a resection of the capitate head and put an interposition.
Interesting. Yes, it's
because I don't think it's definitive treatment. I think that the best treatment for him maybe is the mid-carpal fusion. Okay, but or something like this. But if he doesn't want anything big, we can try this kind of solution.
Yes, thank you. It's one of the possibility. Ezekiel, I can see also. Yes.
For this case, probably my treatment will be an excision of the capitate head without any interposition. I do not use interposition for this kind of cases, and probably, and I don't know if it's gonna work or not, but I will probably add a cord decompression of the radius for a case like this one, because of the lunate necrosis and that situation, and that's it.
Okay, thank you for this option. We need to remember the patient needs a one-shot surgery here, because he had already 2 surgeries before, and he wants one surgery, and we need to discuss with him. I needed to discuss with him a lot before. Any other option? I can see Gustavo, he just connected, but Gustavo, we are happy to see you. Have you seen the case or not?
Yeah, I see the case. Hi, everybody. So I totally agree that perhaps the excision of the proximal pole of the capitate with the interposition may be not the definitive treatment, but because I think this is a manual worker. I agree with Lucian that perhaps a mid-carpal fusion is the definitive solution, and that is what we have to talk with the patient, because if you see the sagittal view, you can see there that the hemate is completely included in the bone bruise. So I think that we should include the hemate in the treatment, because otherwise, if we treat just the capitate, perhaps in the future, patient will still have pain.
Thank you, Gustavo. Actually, I agree. And about that is a total mid-carpal arthritis. I had to deal with this, and I had to deal with the patient for one such surgery, and we will show you after what I choose. The comment or question for Paola. Hello, Paola.
Hello, Alan. Hello, everyone. Yeah, I think that it's very important what you said, that this patient doesn't want any hardware, but the main problem is pain. So I think if we resect the proximal pole of the capitate and put something in third position, the results of that, the outcomes are not very clear. So if we can talk to the patient and maybe I will try to remove the lunate and go for a scaphocapitate fusion, and then resolve the problem with good results.
Remove the lunate and scaphocapitate fusion.
Yeah, as if we're at Kimbuk, you know. So the problem is in the mid-carpal. So yeah, you remove the lunate, so the capitate doesn't articulate anymore.
Yeah.
And then you do the scaphocapitate fusion.
Someone has any
that
comments?
The radiocarpal joint is good, right? So.
Radiocarpal, I'm not sure, but I think almost the dorsal region suffered a little from the first surgery. Someone has any comment or answer for Paola option? Anyway, what? Yes.
No. But my only question is, it is quite clear that the most definitely treatment for an issue like this one, it will be any kind of partial fusion. But but this patient is saying that he doesn't want any type of hardware in the wrist. So that's the problem. How can we do it without any kind of hardware?
I will thank you, Ezekiel. I had actually a problem to convince him. I proposed the partial fusion initially because for me it was the best therapeutic option, and it was very, very difficult to convince him of any treatment he wanted, just to not to have pain anymore. And after a long discussion with him, I choose a controversial option, and they will I had to make a choice, and they will present the therapeutic option.
All right, those are great choices, by the way.
Yes.
Okay, so we moved on. We proceeded on to do a proximal row carpectomy with a dorsal capsular flap. So unfortunately, these are the only pictures, but we have more pictures on the second case. But we did a extensile incision over the dorsal aspect of the wrist. And then we sort of exposed the extensor tendons and retracted to one side. And the picture on the left is essentially showing the markings or preoperative markings of the proximally based dorsal capsular flap. And you can see from the middle and the right picture, that's where the flap that was already harvested, it is vascularized and is flipped backwards. You could see the carpal bone. So proximal row carpectomy is then performed, and then the dorsal capsular flap is then stitched onto the volar capsule to interpose between the capitate and the lunate fossa. So we don't have the post-operative pictures, but at about, we've seen him about 1 year right now. The last follow-up was in May. He's got really good outcomes. In terms of range of motion, it's still lacking from the pre-op, but most importantly, the pain has improved and the grip strength has improved. And you can see from the post-operative X-ray as well that the joint space or the radiocapitate joint space is relatively well preserved. Now I'm going to move on to the second case, which is pretty similar. Essentially, it's a 60-year-old female right-handed.
Just please,
Yes.
Zay, thank you for the first case. Thank you, everyone. We will discuss at the end because it was a very controversial decision I made for this patient. So feel free at the end for the discussion to tell everything you want about this option. You can go on, Zay.
So this is a retired 60-year-old female who does a lot of manual daily activities at home. She had a 4-year history of left wrist pain as well, but we don't know what trauma she had. She couldn't really recall, but it was pretty disabling and sort of disabling her from doing activities of daily living. If you could see from the table as well, she's got quite a significant reduction in the grip strength of 3 compared to 22. And there's tenderness, mainly in generalized tenderness over the dorsal aspect of the wrist at the central wrist region. Now, the X-ray was performed. This was done in a previous center, but she had 2 corticosteroid injections somewhere else. But according to her, it was ineffective, and hence she came to us for a second opinion. The X-rays on the right side, these are the X-rays, but you could really appreciate that the scaphoid looks a little bit flexed where there is a scaphoid ring sign. The scapholunic interval looks a little bit widened, but the entire carpus looks a little bit shortened. The mid-carpal joint looks a little bit reduced. There's a DRUG arthritis, but she's a 60-year-old female, and there was no pain over the DRUG region. The lateral X-ray, you could also see that there's a maybe slight narrowing of the lunocapitate joint, but the lunate looks relatively neutral. The X-rays on the left essentially showing that this patient had a corticosteroid injection, and then the previous doctor actually injected contrast, and this was how it looks like, but the contrast did not go to the radiocarpal joint. So anyway, we perform an MRI because of the persistent pain and disabling, and you could appreciate that on a lateral view, the lunocapitate joint, you can see that the bone is essentially kissing one another. There is some step over the scapholunate region, and you could see in the axial view as well, there is some widening over the scapholunate joint with a possible interruption of the dorsal scapholunate complex. So the therapeutic option that we offered in a 60-year-old female is a similar one, which is a proximal row carpectomy with the dorsal capsular flap. So this is a more detailed intraoperative picture where we did an extensile incision. You could see that we sort of removed we retracted the extensor tendons out of harm's way, and this is the incision of the dorsal capsular flap, which is proximally based. You could see that the dorsal capsule is actually flipped proximally. You could see that the proximal carpal row, and also you could appreciate that the capitate cartilage is quite eburnated. So the picture on the right shows the process of doing a proximal row carpectomy. And again, this is a zoom-in picture of the capitate head. You could see that the cartilage is pretty eburnated. And the one and the asterisk shows the proximally based capsular flap. So the dorsal capsule is actually stitched on to the volar capsule. And this is the middle picture, basically shows the soft tissue interposition between the radiocapitate joint. And the X-ray shows that the joint space are pretty much well preserved. So this is about 7 months post-op, reasonable range of motion, and patient is really happy actually. And yeah, overall the patient is pretty happy with the outcome with no hardware and quite pleased. Would you like me to move on to the discussion?
Yes, I think just to the discussion, and we will discuss at the end for the whole case and the whole discussion. I think that.
All right. So in terms of discussion, I think the real goal for these treatments is patient satisfaction and happiness. And for the past two cases, the patient is pretty satisfied because the pain is actually, resolved. So really, the goal is actually reduction in pain and preservation of motion. And if patient is happy, surgeon is happy. So there are other factors to consider. Number one is the cost of surgery, durability of the procedure, the complications of surgery, and obviously the need for secondary surgery. So these is a pretty exhaustive slide, but there are a lot of papers talk about the key differences of the proximal row carpectomy and four-corner fusion, the advantages and disadvantages. But this paper that was published in 2021 basically looked at the never-ending battle between PRC and four-corner fusion. It's a systematic review and meta-analysis. And basically what they found that there is no difference in all outcomes for these two procedures. And they suggested that they recommend proximal row carpectomy because number one, it is the easier procedure. And number two, you avoid any hardware issues. Now, when we look at the longer term outcome of proximal row carpectomy at about a mean of 6.5 years, in 6.5 years, they noticed that 45% of the patient had developed moderate to severe radiocapitate arthrosis. And these patients are more prevalent in smokers, those who are laborers, and those patients with type 2 delay. But having said that, despite these patients developing arthritis, not all of them correlate with clinical outcomes. So, but to me, 45% is actually pretty significant. When we look at patients with Kienbock's disease, this is a little bit off topic, but essentially they look at Kienbock's disease stage 3, where the lunate is collapsed. The two groups where the PRC with interposition, PRC without interposition, they found no difference in outcome, but this is only at 1 year follow-up. These paper basically looking at midterm outcomes at about 6 years, and basically what they found was that patients with pre-existing mid-carpal arthritis that underwent PRC and dorsal interposition versus patient with no mid-carpal arthritis that underwent PRC. And they found that in these two groups of patients, the outcome is actually pretty similar at 6 years follow-up. This means that we can consider PRC with dorsal capsule interposition in patients with mid-carpal arthritis who traditionally we would have undergone a four-corner fusion. Now, a few more papers, okay? Just finishing soon. But essentially, this is another paper by Big, which is a Korean team, looking at PRC with dorsal capsular interposition with patients with advanced arthritis. And they found that although the sample size is very small, there is a significant improvement in pain and the patient functional score at a mean of 40 months. 3 of these patients had a narrowing of the radiocapitate joint over the months, but their patient-rated score was not significantly different from the rest. So we have talked about many other options. I think they are all really good options, like neurectomy, which is also a good place to discuss, paracarbon implants, dermal allograft, fascia lateral allograft. But I just want to pick on the dermal allograft because recently I came across it and I thought it was quite interesting. So this paper that was published by Steve J. Lee in a 2021 paper looked at 9 patients with PRC with decellularized dermal allograft with pretty good results at a mean of 18 months. They found that the range of motion and grip strength was at least 80% compared to contralateral and is a really good option for patients with mid-carpal arthritis. And there's a maintenance of radiocapitate space as well. So this is just a photo, basically looking at the dermal allograft. There's actually is an allograft of the human's back, and this is how it's measured. He usually uses about 6 centimeter by 5 centimeter in size and fold it into half. Each dermal allograft is about 3 millimeter in thickness. So when you fold into half, it's about 6 millimeter. So basically, he stitched the corners of the dermal allograft and stitched in the middle to prevent shearing, and sort of anchored this dermal allograft between on the capitate as well as the hamate in the non-articular surface. And basically, this is how it looked like. This is a cadaveric model where he anchored the dermal allograft into the mid-carpal space between the lunocapitate, the radiocapitate joint. And you could see that it's pretty stable and it's not really coming out. And from his paper, he found that the radiocapitate space is maintained. So the left two X-rays basically shows immediately post-op. The right two X-rays shows at final follow-up, and the space is still pretty well maintained. So I would say that this dermal allograft can be considered, for example, if the capsule is too friable or thin, or in revision cases, because one of the cases that he had in this study by Steve J. Lee, he had a four-corner fusion that failed at non-united. And so he had to take down the hardware and perform this procedure. And the patient had a satisfactory result even at 16 months after. Yeah, so thanks for listening.
Thank you so much, Zhe. Could you please stop sharing your screen so we can discuss? Thank you. I know it's a very controversial therapeutic option, but the aim of this presentation was really to open the discussion about the third therapeutic option when we have such cases in the mid-carpal arthritis. We don't really want to put an implant such in the second case in the old women, because sometimes with the capitate implant we have some issues, or in young patients when we have very difficult patient to manage. We need to have a plan B, or sometimes in some revision cases that are some very difficult. We would like to go on one-shot surgery, and I feel comfortable, more and more comfortable with this therapeutic option, but the discussion is open. I know it is controversial, and we can start. Thank you, Zhe. We can start with Lucian. You can. We don't hear you. Yes, Lucian.
Yeah.
Please.
No, I wanted to say that proximal row capectomy with capsular interposition, it's a very well-known and antique procedure. It is used by a lot of people, and has its meaning and its logics. I think that it really depends on the patient. Okay, who's the patient? What kind of activity does the patient? Okay, I think that in a manual worker, I won't do it. Okay, because I prefer to have a more stable joint, a better grip strength, and I think it will last less than a mid-carpal fusion. Okay, but in an elderly woman, it can be an option. Okay, I did also about 20 cases of chondral graft to the capitate with PRC. The graft was taken from the lunate or from the triquetrum, and it had good results, but they weren't a manual worker. You know, there were people that didn't do nothing special, normal people that didn't want to do a mid-carpal fusion. Okay,
thank you, Lucian. Actually, for the manual worker here, I discussed very long. There was a long discussion with him before, and I told him it could be we could fail choosing the PRC, and he told me, okay, it's not a problem for me, and he chose the PRC with the interposition. And now, after 8 months, he went back to his job, to his work, to his manual activity. He just stopped the physiotherapy because of economical issues. And I was surprised about the outcome in this patient. Yes, I think
that those patients go well. You need to see them after 10 years of manual working, 15 years, and we see them in the office. You know, those are the patients that do total wrist fusion or do a prosthesis or total wrist prosthesis.
Yes,
okay?
I totally agree. For
but
the
I think
elderly,
it's a good solution.
Yeah, to discuss. Thank you, Lucien. Vitaly.
Yeah, thank you, Alan, for the two cases. Just one question, especially in the second case, do you think that RCPI can play a role or not? Even as a B plan, even as a B plan.
That is the discussion for the capital head. We have some, I prefer to avoid capital head because we don't have, in my opinion, we don't have a big series and long follow-up. As far as I know, only one series, and sometimes we can see some issue with the implant, with impingement with the head or something like this. And if you fail with the implant, you will have at the end bone loss on the capital head. It will be difficult to deal with the case. That is also only my point of view. That is why I avoid the RCPI implant. And in some countries, the pyrocarbon implant is not available. So the interposition with the soft tissues interposition, or using the dermal allograft, or combined techniques with the dermal allograft with the soft tissue is a kind of seducing technique for Lucien. And I don't know what other panelists think about this. Lucien, Fabio, or Ezequiel, what do you think about this technique? Ezequiel is not happy. We can see that.
No.
What do you think?
No.
I'm just kidding.
I believe that that's a completely reasonable option for case 2, but it would be by my treatment for the first case. For the second case, a 60-year-old female retired, for sure. I believe that's a great alternative, but not for the first case. Not in a young manual worker. That would be my choice. But I know that we have literature to defend both places. I mean, you can argue that PRC is as good as four-corner fusion, and we can discuss that for 1 hour.
Yes, I think for the second case, what would be your preferred therapeutic option in the elderly patient, for example?
Yeah, I probably the same one that you chose.
Okay.
It's like that would be the only comment that I have is I have no the first that the dorsal capsule. I believe that's a comment that it is not vascularized because as soon as you put load on that flap, the vessels reaching that capsule are gonna die. It's like it's so. It basically behaves like any other type of interposition that it is not vascularized. And I have no experience using dermal allograft, so I have no comments about that. But I believe that the outcomes are with no interposition and with dorsal capsular interposition are so similar that just to add more cost to a procedure using an allograft like that one, I don't find that necessary, or I mean, it would be really difficult, at least in Argentina, for an insurance company to order that and to have reasonable explanation. Well, that's the only comment that I have.
Actually, for the capsular flap, in the primary cases, we have a good flap when it's not a revision case. And I think for the moment, for the dermal allograft, it could be interesting in the revision cases when we have the dorsal capsule has been already open. So it could be a good option for in these cases. Thank you. Tell me, Ezequiel.
No. That's actually I treat a lot of revision cases, and I found the capsule thicker than in the first cases. So I do not have it was never a problem for me. And as Paula asked in the chat, every time that you use that technique, obviously we are sectioning the PIN, so the partial denervation is included in the technique. It's like this.
Someone would have done denervation in this case, and only denervation? No. Nobody
the first
believes
one?
in nervation. Yeah.
In the first one?
Yeah.
It's an option. Someone in the north of Europe will absolutely will choose it, like in Belgium or Holland. Yeah, they are doing a lot of them, but I don't know. I don't think it's last a lot. I think the effect of the denervation finished after a while, and in manual worker it finishes quite early. In my humble experience.
In my opinion too. We have Marta. Do you have a question or a comment?
First, I have seen Professor David Warwick do the case of total risk denervation in old age, but I'm not sure this work if in the case of elderly patients, low demand patients, that option may be good for that kind of patient, because I've seen in UK Professor David Warwick do it in the elderly patient. They do total denervation, PIN neurectomy, neurectomy, and some dorsal cutaneous nerve. So do you have any experience or about that?
For me, the denervation in the can be a temporary option, but as Lucian said, it will not last. We need to try to find a good solution, that is a definitive solution. So thank you for the comment, Mort. Is there any comment or any other question after this case? I can see not. So thank you everyone for connecting. Everyone, Mort, Fabio, Clément, I can see Zé, Tadeusz, Paula, Lucian, Leo, Ezekiel for the first time. We were happy to see you. Vitale, Carlos, Andrew, who couldn't be here. Gustavo, who was here just for a while. The next symposium will be the Seasonal Risk Forum in Strasbourg. It is a combined session with the IRCAD IWC course. So it will be in 3 weeks. You will find all the links to register on the Instagram, the LinkedIn. So once again, thank you everyone for connecting and for joining, for your comments. I wish you a very nice weekend and see you very, very soon. Bye-bye.
Bye.
Bye-bye.
Thank you.
Bye.
Bye. Thank you.
Bye.
Bye-bye.
Thank you.
Thank you. Bye.